criteria to be in the program because it's a medical program and Medicare has pretty strict eligibility criteria. So a little bit some entertaining information at the beginning. So look on a positive news. So 1900 we will Americans will live in 48 years. In average, it's like life expectancy. Now in USA, we have 79 and few months, which is just 36th position in the world. So Japanese live 89. So they live much longer, 10 years longer than Americans. And this is beautiful. This is great. We really live long now. But for sure, we have unintended consequences. You know, every coin has another side of living longer. And it brought just for last probably 50, 60, 100 years new challenges. People usually died very suddenly in the past from acute disease. If you are fans of Middle Age history like I am, you probably see that King was 40 years old, was fine, had a good time, and next day he's dead, or 2 days later he's dead from some disease. Um, Today, people very rarely happens, but very rarely dying immediately. So many of them die from chronic diseases after many months or many years of suffering. And cancer can be many, many years of treatment, congestive heart failure, dementia, Parkinson's, all those diseases, if you think about, they are mostly chronic diseases and can be for many, many years. People usually in the past died at home, and it was part of life. It was not accepted as dramatic as it is now, because people were seeing this death in front of them. Um, 80% of Americans express the wish to die at home. 80% of Americans die in facilities or hospitals nowadays. And I believe home care, like Visiting Angels, for example, plus hospice agency as Jessa Hospice, together we can work very, very hard to let people be at home until the last breath and be comfortable and get medical care, skilled nursing from hospice, plus day by day, hour by hour care by home care agency, again, like Visiting Angels and some others. Uh, we are conditioned to believe that something always can be done to fix the problem. We are so impressed by the medical progress, new inventions in the medical field, that we absolutely are absolutely sure that all problems could be fixed, at least today, and tomorrow we don't know, but we hope today. So we're looking for this fixation of the problems instead sometimes of thinking about how to make this last period of life, and it's still about life, comfortable and joyful. So most common myths about hospice. So I will go through myths, then I will go through facts, although while talking of the myths, I also will talk about facts. So hospice means giving up. And again, my job every day, I'm meeting the families of potential hospice patients, not all of them signing for the program, but many. Let's say 50, 60, 70% of them. So, and some of them saying, like families, I don't want to give up on my mom or dad or my husband, wife. I don't want to stop medical treatment because I feel it means giving up. Um, Hospice is not to give up. It requires some heroic decision. I can say it personally, not as a nurse, but as a daughter when I make it for my mom. 3 years ago, very difficult decision. I can say probably brave decision to make her comfortable and make her happy instead of doing a lot of, I'm sorry, a lot of unnecessary and unfortunately treatments. So it's the care will not be stopped. It will be refocused on another goal, so on providing comfort and quality of life. Another myth is that hospice is only for cancer patients. And this myth comes from the history of hospice. The first in United States of America, hospice was in 1970s. In Great Britain, it was 1960s. And in 1960s in Great Britain, the hospice was created, was built as a house where all medications were given to alleviate the symptoms of cancer for cancer patients, because those patients most often suffering from pain, shortness of breath, etc. So, but we have here information from 2017, but it's not only 2017. For now, it's also like cancer is probably 17, 20, 25% as the most hospice patients. We have dementia. Probably this is probably the majority of people, because dementia is a terminal diagnosis. And when people telling me, oh, the clients families, oh, my mom has absolutely great health, just dementia is a terminal diagnosis which inevitably bring in person to death. Heart failure, Parkinson, so different types of neurological diseases, strokes. So there could be many diseases, not necessarily cancer. Another myth is hospice is where patients go to die. This is exactly myth which comes from British movies or European movies, because when we watching them, we see how people who are terminally ill packing their luggage and go to die for few months, probably to stay in the hospice. I just recently watched a movie where the young lady with the cancer packed her luggage and she went to stay in the hospice to be on some comfort medications for a couple months before her death. This is not in United States of America. In United States of America, it's a program which follows the patient where he or she lives. It could be private residence, it could be assisted living facility, it could be nursing home. I will talk about these small houses which call inpatient hospice in United States. This is completely different, not completely, but different goal than the same houses in the Europe, in the Western Europe. So hospice is a program package of services and 99.99% of hospice patients live in their facilities, homes, private residences, and getting help through hospice program. Hospice means death is imminent. Studies show exactly the opposite. Yes, we need to have some terminal diagnosis to accept the person for hospice care. Again, it could be cancer, dementia, Parkinson's, or other disease. But death, it's honestly better than death is not imminent yet, because person has 6 months, 9 months, 10 months, as long as this person is eligible, medically eligible to get the care. And it will be hospice responsibility to show to Medicare that this person is still eligible, although they're already on hospice 6 months or 9 months. Jimmy Carter, former president of USA, he was on hospice 18 months. Unfortunately, people in average enjoying the hospice program or benefiting from hospice program 10, 11 days. Some people can be many months, some people can be just few hours. We don't do anything to prolong life, although we don't do anything to enhance the death. So we just provide comfort and support the patient and family during this period of life, because again, I'm stressing it's about life. It's not it's about death, but as a part of life. As it's just one part of life. We want our wedding to be nice. We want our birth to be uncomplicated. We want our life to be nice. This is about the ending of the life, which we also want to have nice. Another myth, patients have to give up their doctor to enter hospice. No, we actually very much prefer that the patient has attending doctor. Usually it's a primary care provider. Usually, sometimes family or patient has a long-standing relations with primary or with the oncologist or with cardiologist. They choose the doctor they want to have as their attending doctor. Our doctor, hospice medical director, we have two doctors. They are rotating, they are 24/7 covering the calls, and the nurse cannot give medications without consulting with doctor first. They are like consulting, like you have your cardiologist for heart problems, pulmonologist for your lung problems, you have hospice doctor for your comfort problems. And this doctor is available to help. So it's second doctor. If for some reason the family does not want, they don't have like good relations with primary, or they're not so much emotionally attached, or it's difficult to reach this doctor, or doctor says, no, 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 I don't want to follow when my patient is on hospice, it's perfectly fine to have just one doctor, and it's usually our doctor, hospice medical director. Another myth is that hospice requires DNR, which is like no CPR, no intubation, so do not resuscitation. So we don't require it. We definitely will go through most, which is like your wishes, what you want to be done in the end of life. Do you want, not in the end of life even, what you want to be done if you have infection, if you need blood transfusion, if you want to go or not to go to the hospital. Do you want chest compression if the heart stops? Do you want intubation if you cannot breathe? We will go very in details over this document, which again, MOLST, MOLST, you can download it on, just Google it, or you can find the same, it's advanced directives, so it's pretty close to most. So there is a lot of like documents in Maryland, for example, and Virginia, I'm sure, to reflect your wishes, but you don't have to be DNR to be on hospice. So it's not must thing. Another myth, which I very, very like to stress, once the patient elects hospice care, there is no turning back. You always can change your mind. Up to the point, I had many cancer patients who come in because chemotherapy does not work any longer. They are sick and tired of the treatments. They want comfort. We are taking them for hospice care. We put in symptoms under control. They don't longer have nausea, pain, etc. And they feel stronger because they didn't get chemo for a while and symptoms under control. So they go in to visit their oncologist. Oncologist telling, okay, let's try another chemo or trial or whatever. And they telling us, thank you so much. We thank you for your care. We very much enjoyed it, but we want to go back for aggressive treatment or curative treatment. It's absolutely fine. Just one signature. It takes 1 minute, and the patient goes back on aggressive treatment, Medicare or other insurance start to pay back for aggressive treatment, for curative treatment, and stops to pay for comfort care like hospice. A few months later, it does not work. They want hospice back, or they have chemo break or something like this. They come in back, we take them back. There is no limits in and outs, at least by Medicare right now. People can change their mind. People can go to the hospital and change their mind and go to aggressive treatment there and call us again when they live in the hospital. Hospice care is limited for 6 months. I just mentioned Jimmy Carter. He was with us, not with us, but another agency, 18 months. So it's not limited for 6 months. 6 months idea or word came from hospice eligibility criteria. Because when we're looking for if this person is eligible for hospice care, other than terminal diagnosis and decline and etc., I will talk about hospice eligibility a bit later. We also, our doctors sign in the certificate, verbal certificate, that if the disease will go in its natural course, this person most likely will die in the next 6 months or less. So the question, I'm doing eligibility assessments almost every day. And the question which sometimes my supervisor asked me when I'm doing the reporting here about eligibility, do you think this person will die in a close 6 months? Will it surprise you? And if the answer is no, it's one of the eligibility criteria. But again, if we are able to confirm that, or we are proving that this person is still eligible for hospice care, we can continue to provide the care beyond 6 months, sometimes beyond the year. Another myth. Hospice medications like morphine hastens death. Oh, this is my favorite point because I'm doing this education with nurses in facilities, etc. And they all many of them, let's say, under impression that we gave them morphine and the person died. It's not right because morphine is a very good medication to manage the symptoms like pain and shortness of breath. Those who are very short of breath, morphine is the best one. The dosage which we give in sublingual, so just drops in the mouth, absorbed by mouth, usually it's 5 milligram every 4 hours as needed. It's like starting dose, which definitely could be changed. It's nothing. You cannot become addicted from this, even if the person who is in a deathbed can be addicted, which I doubt. They cannot be addicted. They cannot be high on this dose. It does not hasten death. It's a very good medication. It's a small dosage. And also, I'll give you example. As I mentioned before, I used to work in suburban. I was, again, acute care nurse in a cardiology mostly. And we had a lot of patients coming with a chest pain. Chest pain, we don't know it's heart attack or it's just indigestion. It could be both, by the way. So I usually get the standard order from the doctor. For chest pain, give nitroglycerin, this dose, blah, blah, blah. If it does not help, give 2 milligram morphine intravenously every 4 hours as needed. So it means that 2 milligram of morphine intravenously, it's pretty like light dose, but pretty much equivalent to 5 milligram in the mouth. So, but these people didn't come to die in suburban hospital. They came to be treated and hopefully the problem to be fixed. And morphine was just one of the medications which was automatically in the profile. I didn't need any a special order for this. I had it as a profile as a needed order. I'm sure you know people who get in morphine at home as a pills for many years. For back pain, for cancer pain, for arthritis pain, and nobody died yet from medication. So morphine is a good medication by any different parameters. And sometimes families refuse it because of some prejudices or because of their beliefs. It's fine. We're trying to do some education. If they don't accept it, nobody will force them to have morphine. But we're trying to do education. It's sometimes unnecessary suffering because of biases. Um, it's 10 is also very important thing. It is another myth is it is the doctor's responsibility to raise the subject of hospice care. We like because I'm a liaison, I'm a nurse liaison, I'm doing analysis of referrals over every month. And I can see that most of the referrals, like 50-60% sometimes, coming from the family members. Doctors giving 20-25, 20, probably the most 30% of the referrals. The reason very different. Sometimes doctors don't see their patients for many months and did not see or notice changes until the patient went to the hospital. Sometimes people just, oh, mom is 100 years old, I don't take her to the doctors any longer. Sometimes, honestly, as I mentioned, I'm the part of these conversations. It's very difficult conversation. It's very difficult and again require a lot of courage and knowledge to see what is going on in general, not just like infection, antibiotics, cancer, chemotherapy, I don't know, dementia, Aricept will help with dementia. Poor appetite with dementia, we will give something to like steroids to improve appetite. It does not, they, the reason is that this discussion is very difficult. It takes a lot of doctors' energy, time, and it's actually make them feel very bad as a human beings. So you sit in with the family, you tell them, you know what, don't you want to think about hospice for your mom? And you see the crying, the tears, no, doctor, you cannot do anything any longer. So I was on these conversations with physicians, including physicians, very upsetting conversation, very sad one. I don't want to say it's much easier, but yeah, it's probably much simpler to treat the different problems which is coming. Patient in the hospital with infection, give antibiotics. Next week, patient with in a hospital with a heart failure, give something for heart failure, etc., etc. So until the problem is really bad. So family members perfectly can call us, ask and take department, and we get on these calls every day. So, hello, my mom is Mary Smith. She has dementia. She lives in the facility such and such. Recently my mom does not eat enough. She's very calm. She's sleeping most of the time. Can you please do evaluation for hospice care? We don't need doctor order for evaluations at all. or information session. We're talking with you now without doctor orders. I'm talking with you now without doctor order. We can send the registered nurse. I'm doing it all the time. I'm going, I'm assessing, I see the patient, I see the medical records. I'm talking with the family members, with the caregivers, calling my supervisor if I have doubts. If I don't, I just schedule admission if family agreeable, because two things should come together to be on hospice care. Patient is eligible according to Medicare standards, and this is only our evaluation. Only. So hospice doctor has to confirm that this person is eligible. It does not take long. It takes like few minutes to get this yes or no. And family agree, or patient himself agreeing for the hospice. These two things must be together before admission happens. And sometimes patient is eligible, sometimes we give all information and family still says, no, it's too early for us, we want to go and do rehab or treatment, etc. Nothing wrong about this, it's just another way to go, but at least they try to do some assessment and they get information, and this information will help them to make decision probably later. Okay, now we go into facts, which is like very much overlapping with the myths. Hospice care is a choice, and I would add it's a philosophy, because sometimes people don't even have bad diagnosis. Some people calling us. I had patient 103 years old last month. I was trying to bring her to the hospice 3 or 4 months, and her daughter just was right. She didn't want to send mom to the hospital. She wants to get comfort care for her in the facility. But the patient, 103 years old, was able to walk, was eating very good, was confused but still talking with us. She did not have any infections or hospitalizations in the last couple years. I could not bring her. So philosophy was saying, I want hospice. Medical treatments, medical condition was not enough to be on a hospice care. Uh, so is a choice. It's a choice and philosophy. Uh, so I already mentioned it many times. Hospice is not curative care. It focuses on comfort, but I know the question will be, so do you stop all treatments? Do you stop all medications? I'm sure this will be the question because I always get these questions. No, we, when somebody admitted for hospice care, it's a long admission, like couple hours admission process, when admission nurse goes through every medication on the patient list. Some of them will be there. Nobody care. We are okay with the heart medications, blood pressure medications, I don't know, dementia sometimes. So many medications will stay. Some medications for comfort will be added just in case if patient is uncomfortable. Some medications will be stopped. I am absolutely sure that chemotherapy will be stopped for cancer patients, because you cannot have chemotherapy paid by Medicare and be on a hospice care paid by Medicare. Medicare would like you to choose curative treatment with their chemotherapy or hospice for comfort. Some medications, I don't say about chemo, it's very expensive. That some medications people still want to continue. Medicare does not pay for them. Hospice does not pay for them. They choosing to pay out of pocket. Some of them, they just finish on the supply they have at home, and after that think about this. So it's always discussion about medications, but my answer, we do not stop all medications on hospice care. Treatment. For example, the patient is on hospice care, we suspect it UTI. So we can do some urine test, we can see its infection, we can start oral antibiotics at home. We never ever will go with intravenous antibiotics treatment at home. It's already for hospital treatment. Or we suspect it's pneumonia, we can bring machine, ask X-ray to be done. We see it's pneumonia. We can do oral antibiotics again at home. We don't pay for intravenous antibiotics at home. So there is certain treatment, but I can say light or conservative treatment, a not very aggressive one. Okay, very important fact about hospice. What is it, hospice? So hospice is, as I mentioned, is a package of services. One point is equipment. It's much easier to get. For example, if you have experience with to get at home oxygen, for Medicare, you have to show that this patient has very low oxygenation and needs oxygen at home. If oxygen is beyond whatever 90% pulse oximetry, like upper than 1991, you cannot get oxygen paid by Medicare. In hospice, we don't ask this. I know that this patient is short of breath many times a day. I just send oxygen. We send hospital bed, Hoyer lifts, bedside commodes, all other things which needed. It's part of the package, not extra charge. So it equipment, supplies like diapers, chalks, gloves for caregivers, etc. And the most important is the people. It's hospice team, which is medical director, so physician, which I mentioned already. Attending physicians, stay if you want. But the team is itself nurse, social worker, chaplain. Nurse, social worker, and chaplain usually visit the patient next day after admission or 48 hours later, like 24 to 48 hours after the admission done. Again, nurse, chaplain, social worker, three people from the team visiting as soon as possible. Nurse will be, we call them case managers. They will be with you for the rest of the journey. They are the most frequent visitors. You always can say that we don't want chaplain, we don't want social worker. I always recommend to meet all three of them at least first time because they are clinical chaplains, they are clinical social workers, they are interfaith chaplains. We do have different faiths for sure. Social workers can help with their community resources, give you some connections, very important visits. They will be the same people for the rest of the journey. They can order also hospice aides visits and volunteers if you want. Basically, nurse is the only must person. And doctor, hospice doctor. Hospice aides, chaplain, social workers, volunteers is your choice. Now, next question is always how often the hospice staff will visit my mom or my dad or my husband, my wife. It depends on case. So as a minimum, so it should be routine visits and extra visits as needed visits. Routinely, the patient should be visited, be visited once a week. If nothing special goes on, if this patient has a lot of symptoms, nausea, vomiting, pain, shortness of breath, it could be every day. It could be at 9 a.m. in the morning, same day you call in 3 p.m., mom is not good, can you come again? Or 3 a.m. you can call. We will send the nurse during the night time. We have staff working 24/7 to visit the patients. So if we kind of guessing and we have symptoms which help us to guess, we that this is the last week of the life, we trying to visit every day. We doing our best to visit every day because we must be sure the family is ready to lose the loved one and the patient is ready to go. And most important, the patient is living comfortably. I'm sure the hospice aides is the most beloved people because they come in, they wash in the patients. The question is how often? And some people haven't visited angels as a home care and hiring like many hours a day. And thanks God they can afford it or they getting help to do it. But hospice aides hospice package was built by Medicare as a supplemental care and support at home. These beautiful words wrapping the pure fact that hospice aides come in from 1 to 3 times a week, depends on the case, to wash the patient, to change the patient, to help their private duty people and leave. So basically, they have scheduled visits. They have 4 patients a day, usually 2 hours for each patient to visit, and like they need also to drive, etc. So it's like hour and a half goal oriented visit. It's still very helpful, especially for those who are at home, because it's a huge thing to have a bed bath professional done bed bath. But if few hours later the patient has bowel movement or needs to be changed or something like this, you cannot call hospice and ask, can you come and change my mom? You can come, you can call and say, please come because she cannot breathe or she's in pain, but you cannot call and ask us to do changing because it's again personal care, it's a supplemental care. That's why hospice agencies so great collaboratively with home care agencies. Because home care agencies provide everyday care, day by day, hour by hour, communicate with the hospice nursing staff. Hospice provides skilled nursing. For example, Foley needs to be changed. Some tubes should be washed. Drains should be placed or emptied. All our nurses are registered nurses and they provide skilled care nursing. This is more educational kind of slide. So Medicare built the program, hospice program, and every agency must provide these 4 levels of care. Whatever I'm talking now, it's mostly about first one, routine hospice care. And this is almost every patient. 99.9% of the hospice patients across the country getting this routine hospice care, which I already mentioned, at home, in the facility, patient's residence. GIP, general inpatient care, this is these houses which we were talking about. They are not so abundant like in Europe. There are a few of them, one of them only in Montgomery County. There are one of them in DC, I believe. This is what you should understand. It's a very, 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 very short-term decision because sometimes people absolutely rightfully telling like in the hospital, I cannot take mom now because she was before actively taking care of her activity, she was independent, and now she's in the bed, she needs to be changed, she needs to be fed. I just, even with the hospice care, I cannot take her home to her home. Unfortunately, it's not a good reason for Medicare to pay for placement in this house. If somebody like just sleeping in the bed, very comfortable, unfortunately dying, it's not eligibility criteria to be in the hospice house, to be in inpatient care, hospice care. What is eligibility criteria to be in inpatient care? It's only unrelieved symptoms. So I was doing admissions for hospice in the past. I'm coming to the house, the patient, young guy in a horrible cancer pain. I told him, you know what, let's go for the hospice house. We will find the solution for your pain control and we will discharge you home. This is the plan. In a few days, hospice must find the solution for pain control in this house and discharge the patient back home because Medicare pays for this inpatient hospice the same price they pay for hospital stay, like more than 1,000 a day. And they will not do it for many months. If it's like nursing home solution with hospice, probably if somebody cannot provide care at home, or go home with home care agency plus hospice. So we have continuous home care. That's what we're doing pretty a lot. If somebody is in pain at home, we don't take them to the house. We position the nurse in the house of the patient or in the patient place, and we start oh, I'm sorry. And we start even drips to control the pain, etc., just to provide comfort. And inpatient respite care. Every patient in hospice can go to nursing home for 5 days to give respite for the family. We pay for this, we arrange this, and we monitor it. And we provide care for patient during these 5 days. If the family wants more than 5 days, let's say 8, 5 days paid by hospice, 3 days by the family out of pocket. You don't have to determine if this patient eligible for hospice or not. It's our job to do. But this is some tips which saying that this person probably eligible for hospice care. So sometimes they have many hospitalizations in the last year. They have sudden or progressive decline. And usually I'm asking, few months ago, what did your mom what was your mom able to do for herself? Was she ambulating? Was she eating by herself? Or what is she now bedbound? Does she eat now enough? Does she open mouth at all? So frequent infections, any recent UTIs, recent pneumonias, uh, respiratory functions. This is not necessarily part of the eligibility, but could be. For example, with congestive heart failure, people could be on room air for many years, and last 3 months they totally dependent on oxygen. It's a very big sign that probably this person is eligible for hospice for congestive heart failure. Poor appetite and weight loss is my like favorite thing because it's very important. So this is I always searching looking for weights, and this is very difficult thing to find sometimes. So up to the point that I'm not sure, I'm calling to hospital, I'm calling to rehab, I'm calling to assistant living, I'm calling to the doctor's offices. What was the weight of Mr. Smith year ago? What it was few months ago? What it is now? It's very, very important. Unintentional weight loss is a huge parameter for hospice eligibility, and it's not only for cancer, it's for almost every diagnosis. But again, let me stress, you can suspect that somebody eligible, but we will prove it or not. If we will not be able to prove it now, we always can come again in a month for a few weeks, so you can call us again and we will do it another time. This is Medicare pays 100% for hospice. You sign the paperwork, you ask Medicare to pay for hospice, but you're waiving your right for aggressive treatment coverage, which again, you always can change your mind and come back to Medicare Part A coverage. But it means that you don't seek any longer curative treatment. You don't seek any longer diagnostic tests to prove that the disease progressed or not, because Medicare asks, why do you need diagnostic test right now? What you gonna do with the result? If you want to continue to be treated, so probably hospice is not a good idea for you right now. But again, you always can change your mind, always. We don't need physician order to request evaluation visit for hospice care. I mentioned it already. We will need physician order for hospice if you decide to go with hospice and do actual admission, but it's not your problem. We will call the doctor office and we will get this order. If we will not get this order and you still want to be on hospice and we still found you eligible, we will take you anyway, and our doctor will be your attendant doctor if you want it. We have bereavement program free. After the patient will die, family and caregivers, everyone actually, who feels that they're suffering and they missing the patient, it could be caregiver for many years, not necessarily family member, will have 13 months of bereavement support. It's not only it's sessions. I was myself when mom died, 7 sessions with a social worker for bereavement support. It was very, very helpful. We're doing bereavement services, by the way, for caregivers in the home care agencies. We just got a lot of requests. We're doing bereavement sessions for caregivers in facilities because caregivers feeling very sad when they're losing their clients for many, many years. So why we need to talk, why we are talking today, because this is when we're facing this diagnosis, we are thinking what to do and we're feeling lost. Last week, on Monday, I was with a family in Sibley Hospital, and the daughter told me, I'm so confused. Dad, 82 years old, with a terminal cancer, and they in the hospital continued to offer me CAT scan, like chemotherapy. Let's start chemotherapy now. Like, let's give him another session. And he's not even opening the eyes what I should do next. So was my job and my role to give you different options, which not only hospice, I usually discussing different discharge options. Uh, that's what I'm talking about. Initial consultation, free, call us, no fees. We'll determine if hospice or just a transitions program is appropriate. And definitely you are the final decision maker. Do you need it or not? Just a few words about JESA. It's a Jewish social service agency hospice program. We are agency. We have 40 programs. We serve absolutely not only Jews. We have more than 50% of all faiths. All faiths. We have a lot of staff members speaking million languages, different languages, not necessarily Jewish. Its name comes from 130 years ago when Jews were had to create their own agency because they were not served by other agencies. So we have a lot of different programs, 40 programs for children, for mental health, Holocaust survivors programs, home care, base, like, although we have like a lot. We trying to keep as low patient to clinician ratio as much as possible. So it's around 12, 13 patients. The goal is to have 12, 13 patients for one nurse, which nationwide, it's probably like 20, like 19, 20, etc. So people asking me sometimes, should I stop my home care if I have hospice? No, I hope you understand. You continue with Visiting Angels. They provide care. We cooperate with them. And hospice comes and goes. We provide, like, again, skilled nursing mostly. And very additional, like few hours a week with the home care aides, which will assess Visiting Angels aides with personal care needs. So you have some extra support. We have a lot of volunteers, musician therapy, pet therapy, massage therapy, live music. So people who given their precious time to spend with their patients and families. Again, with diversity, we provide a huge diversity of faith and backgrounds. We have transitions program which unique for JESA. This is for those who are not eligible yet, but there is a decline. So we continue to monitor these people and follow them in the hospitals if they are encouraging them to sign with hospice when they are eligible, although not for sure forcing them to do so. So this is transition program parameters. uh, uh, who don't qualify or not emotionally ready for hospice. The coordinator is a registered nurse, liaison nurse, which is me, and I have two more liaisons. Visit all clients if they hospitalized. We kind of talking and helping to navigate hospitalization process. We don't need physician order, no fee for service at all because we don't charge any Medicare or any other insurance. It's a community program, it's free. And that's it. I'm open to the questions.
All right, that is a very, very beautiful presentation, Maria. So
Thank
we
you.
just have like a recap question here, just one, and I think that's because you had a really, really comprehensive presentation. So
I'm sure.
one important question that I think would be, very important to recap at least because you've already touched upon it. How does one qualify again for hospice, and do most insurances cover the costs?
Yes, unlimited times. You're coming back and forth from hospice. Medicare pays 100%. This is for sure. TRICARE does the same. Most of the insurances, like I can say, like in 10 years with JESA hospice, I saw once or twice that some private insurance pays for hospice 90%, which probably like another few dollars a day out of pocket. Or they pay in just 6 months, that's it, lifetime. They don't, but it's extremely rare, extremely rare. Most of the insurance pay 100% and unlimited time back and forth. As soon as you're switching back to hospice, you paid by Medicare 100%. Yes.
All right, and
I hope I answer the question. Yeah.
yes, what are some of the ways JESA differentiates from other hospice services?
This is a good question. I love it. So I a little bit touch the base. We're trying to keep a very low ratio, very low, because nationwide ratio, like every nurse in hospice has like around 20, 19, 21 patients, which is very difficult. Even if you visiting 5 patients a day, you can do it like just a weekly, and some people like really need more attention than once a week. We trying to keep 12, 13 patients for nurse. This is one very important matter. We are second large hospice in the county. We cover Montgomery County only. We are around 150 patients plus minus in census, which makes us big enough and experienced enough to know how to provide care, and small enough to be very personal, very personal. So like I worked in other agency 3 years, but I'm so happy 10 years with Jessa. Yeah. So like I think we are. And one more thing, you can Google hospice compare, just www hospice compare wherever in the Google, and you will see Medicare website. You will put your zip code. They will give you hospice agencies. Choose whatever, one, two, three, and see what is reviews saying you, because they have parameters and grades and according to the feedback from the families and from the families. One more thing which I forgot to say, we can discharge patient from the hospice live discharge, and we have live discharges from 4 to 10 15 a month, because sometimes people like very stable or even better, and they want to be on hospice and the family want them to be on hospice, but they stop to meet criteria for hospice according to Medicare requirements, and we must discharge them. When we discharge them, family is very sad, because if their goal not to send mom back to hospital, that's what they have to do if they discharge from the hospice, if there is a crisis situation. It's very challenging thing. We're trying to do our best, but sometimes people appealing, family appealing to Medicare, like uh, it could be a conversation and it could happen. It could be your decision to leave hospice, but it could be our discharge according to Medicare requirement as well.
All
Okay.
right. So, yeah, we have 1 minute left until 12 p.m., and I think that is a buzzer beater for us. And of course, for everybody who's watching, the handout's gonna be given out to you via email. So stay tuned. I will be editing this video just to make the viewing experience better, and I will be sharing the link via email as well. So again, I would like to thank everyone who's been here with us. Maria, of course, our expert panelist. And just to remind you, this Visiting Angels Coffee Chat happens every third Wednesday of the month. And we're here to educate, to inspire, and to help those who take care of elders, and of course, our elders, to give them better aging experience, to make that experience in life fruitful up until the end. And that's why we're here. And if you have any follow up questions and follow up information that you might need, just check your inbox and we will be giving them to you. So for the hospice compare, just Google hospice compare, and the number here is 301-816-2676 if you have any questions. So
I
with
will
that
send,
being
yeah,
said,
I'm sorry.
yeah.
I'm sorry. I
Yes,
will
Maria.
send handout. I will send slides to Dexter, and he will forward it to you guys. So if you have questions, there is like phone numbers there. My name is on the first slide. So if you want to talk with me particularly, I'll be happy to help. Okay. Thank you for Dexter. Thank you for this opportunity. Thank you, William. And
All
thank you
right.
all attendees.
hmm With that being said, I hope everybody gets a wonderful continuance of their day today. Thank you, Will, for joining us. Thank you, Maria. Thank you, everyone. We'll see you again next third Wednesday of the month. And again, if you have any follow-up questions that might pop in your head, send us an email. Let us know. Reply to our email. And yes, we'll see you again next time.